Good morning, everybody, and welcome to this first policy response, National Institute on Aging, both at Ryerson University, video town hall on COVID-19, the pandemic, and the future of long-term care in Canada. I'm so grateful that you are joining us today. We have a really fabulous panel with whom we'll have a Q&A, and then we'll be in breakout rooms from around 9:55 to 10:15. And we'll return from breakout rooms, and the event should be over by around 10:25. Really thrilled that so many people are participating in this event. And before we begin, I would like to give the land acknowledgement. We do this as a symbolic and restorative act, one among many to follow and part of a wider and hopefully more transformative reconciliation project here at Ryerson University. Ryerson University, as well as where I am currently located in west end of Toronto, are on the territory of the Anishinaabe, the Haudenosaunee, and the Huron-Wendat. Ryerson is covered by the Dish with One Spoon Treaty, Treaty 13, and the Williams Treaties. We are committed to honoring our obligations to these nations' treaties and to justice for Indigenous peoples more generally. And in this project, we hope to do that by amplifying Indigenous voices through the publication of pieces and building partnerships with Indigenous organizations and communities. And we do have some more work to do in that respect. We do have a contributors fund that we've created that helps pay for pieces from Indigenous and other underrepresented groups in the policy conversation. I also want to show on behalf of First Policy Response and the National Institute on Aging, respect for all those people behind you who maybe can't participate today, who are caregivers, who are in a caregiving situation right now, who are frontline workers, who don't have the technology access, who have other demands on their time on a Monday morning. Those who are participating, we greatly appreciate and respect your participation, and we're seeing some really important personal connections, even in the chat box that's being mentioned now. And behind you are thousands, hundreds of thousands of others who would benefit from this conversation if only they were able to. And we hope that you will take that message back to them. We'll be sharing the video and sharing some of the content from this event. Here at First Policy Response, our goal is to bring together the Canadian policy community, to highlight the best economic and social policy ideas to keep us afloat and together through the immediate crisis and prepare us for a sustainable and just recovery. And we hope that the policy community, and that's a broad community, that includes frontline leaders, those in the private sector, labor, academia, and not-for-profit sector, as well as all the frontline workers, all the frontline caregivers, all the people who are being affected by COVID-19. We hope that you engage with us, and we are especially keen to add voices and organizations that bring further diversity to our work. As part of that, we're really excited to have, as a partner in this conversation, and they've just released a new paper with some innovative ideas on how to respond in the sector to the pandemic with the National Institute on Aging. National Institute on Aging is a Ryerson University think tank focused on the realities of Canada's aging population. Through their work, their mission is to enhance successful aging across the life course and to make Canada the best place to grow up and grow old. NEIA is Canada's only think tank dedicated to policy solutions for an aging population, working at the intersection of healthcare, financial security, and social well-being. And the reports, and you can go to their website, we'll drop it in the Dropbox, and you'll see the many reports they've been doing during the pandemic are founded on the strongest available evidence and original research and led by experts and practitioners in the fields of financial security, healthcare delivery, and public policy. And Dr. Sinha, who's our guest today, is the research director of the NIA. Just to give you set the scene, we'll have 30 minutes of conversation, around 30 minutes of conversation with panelists, moderated by our guest moderator, who I will introduce in a moment. Then questions from you via Slido. To ask questions, please visit slido.com, SLIDO.com, and enter code FPR8. And Famida Kamali, Ryerson Leadership Labs Manager of Operations, is going to give you some information on that now. After the Q&A, we'll have the opportunity to go into smaller breakout rooms where you'll be in a room with one of the panelists, can ask questions in a more intimate setting, and perhaps do more than ask questions. One of the great things about First Policy Response is the opportunity for frontline workers and policy leaders and academics, students, and others to be in conversation with each other, opportunities we don't get often enough. And note this webinar is being recorded and will be posted on our Twitter page, Policy Response, and our First Policy Response newsletter in the next couple of days. Again, First Policy Response is a partnership at Ryerson University of the Ryerson Leadership Lab, the Brookfield Institute for Innovation and Entrepreneurship, and Matthew Mendelsohn. And to get things going, we're so happy to have André Picard moderate this discussion. André is a former colleague of mine at the Globe and Mail, and he's the health columnist at the Globe, author of 6 books, including the soon-to-be-published Neglected No More, The Urgent Need to Improve the Lives of Canada's Elders. André is a hero in healthcare journalism, and don't just take my word for it. He's actually been deemed an official hero by Canada's the Canadian Public Health Association, as well as a number of other organizations. Pretty much any healthcare serving health worker organization at some point has recognized André for his trailblazing work in health journalism. And André was really the leading voice in Canada, has been leading voice in Canada, connecting the people to the issues related to the pandemic, and was the first voice in March who was sounding the alarm in Canada in a way that was just heard nationwide, drawing our attention to the risks of the pandemic and giving incredibly sound policy advice, being fearless in his journalism with respect to what needs to be done to get us to the other side of this pandemic, and calling out where leadership was deficient, where national outrage needed to be directed. And there's perhaps no greater national outrage within this pandemic than what has happened and is happening in the long-term care sector. And with that, I'll give the microphone to André to take us away.
Great, thank you, Karim. Thank you for the overly kind introduction, for overstating my importance, but it's much appreciated. So welcome to our panel, COVID-19 and the Future of Long-Term Care. As you heard, the format's pretty simple. I'm going to introduce the panelists, ask them some questions, and invite the audience to do the same. We're not going to have PowerPoints or anything like that, not on a Monday morning. To ask questions, as you heard, you can use the Slido app. If you don't have it on your phone, you can download it for free. It's spelled sli.do, and it's simple to use. And again, the event code is FPR8, and that is in the chat function. Use the chat function. That's how we interact now in the modern world. That's how we do our networking. So please use it freely to discuss what's being said, to jump in. And if I see some questions float by on chat, I'll try and incorporate them, but they'll be sent to me mostly by Slido. And after the questions, we're going to go to the breakout rooms, have some discussions, and then you can ask our guest questions more directly. So let me, without further ado, introduce the panelists. We have great panel, so you're very lucky to be here this morning. We have Pat Armstrong. She's a distinguished research professor at York University, and she's really the policy guru in this field of long-term care and has been for a long time. So Pat, give us a wave so we know who you are among the many panels we see on our screen. Thanks and welcome. We have Sharon Nwamadi. She's a registered nurse at Hamilton Health Sciences and a Policy and Political Action Executive Network Officer at the RNAO, the Registered Nurse Association of Ontario. It's great to have a frontline worker with us. Hi, Sharon, thanks for waving. And finally, we have Dr. Samir Sinha, who probably needs no introduction. He's been very front and center in the media throughout this whole crisis. He's Director of Geriatrics at the Sinai Health System and University Health Network, and Director of Aging, Director of Health Policy Research at Ryerson University's National Institute of Aging, one of the groups putting on this morning's event. So welcome, Samir, give us a wave, thank you, and welcome all. So as I said, or as you heard from Karim in the introduction, this pandemic, COVID-19 pandemic, has been devastating worldwide, but no group has been hit harder than our elders, especially elders in institutional care, elders with dementia, the most vulnerable people in our society. About 90% of deaths are in Canada are in those over the age of 60, and almost all those deaths, as I mentioned, have occurred in congregate settings, long-term care homes, retirement homes, and so on. We had a disaster in the first wave back in the spring. Unfortunately, we're seeing a very eerie repetition beginning now in the second wave. So we're going to discuss why has that happened, how can we prevent it, and we're going to spend a lot of our time talking about not only the carnage, but how to fix things going forward so that these things never happen again. So I want to start each of you just asking some general sense of the state of the world that you're living in. And I thought, Sharon, I could start with you. So as a frontline worker, give us a sense of How are people holding up on the front lines? We're reading these horrible stories about burnout, etc. So how are you all holding up?
I'm going to say it's hard right now. I currently work with Hamilton Health Sciences and inpatient overflow, which is an extension of the emergency department. And almost every day our ED is in gridlock, meaning that there's patients in the hallways. We don't have enough beds upstairs to regularly admit people for other things aside from COVID, and especially moving into flu season, our healthcare system is already overwhelmed. And I also used to work in mental health. So I worked in both inpatient and emergency mental health, and things there were also getting worse. We had sicker and sicker patients due to the pandemic. There were already not enough mental health supports in Canada. So things are we just take it day by day and do what you can do.
And do you interact a bit with caregivers, with your patients? How are they dealing with this, unprecedented crisis?
Well, right now, a lot of people are just focusing on how they can best care for themselves while caring for everybody else. We've had caregivers have to leave their homes and go live in temporary housing just so that they can't expose their families to COVID. So that takes an emotional toll along with the physical toll of dealing with COVID patients, as they are very, very sick, and it's a lot of work.
Wow. And Samir, you deal with your patients are in their 80s, their 90s, their hundreds. How are they holding up? How are they dealing with this unprecedented crisis?
Some are doing remarkably well. I have to say that I just had my clinic, I have it every Wednesday afternoon. And it's always amazing when you hear a few who, at the tender age of 97 are taking things in stride. And that always kind of makes me quite pleased when I hear, people are saying, I've lived through quite a bit and I'm actually coping well. But that's sadly the rarity. It really lifts my spirits when I realize that some people are making it through in relatively good spirits. But I think for so many of the calls that I do, people are just grateful that someone's still caring about them. They're just grateful that they got a call, that I didn't forget about them, because I think a lot of people are feeling neglected right now. They're feeling, neglected by the healthcare system because their routine care needs are not being met. I feel that, especially for my patients who are residents of long-term care retirement homes right now, I often hear about kind of the varying rules about caregivers who are saying, I'm not allowed to go visit mom or dad now, like, what's going on? Or folks who are residents in retirement homes who basically say, the home's on lockdown. And I'm like, but there's no outbreak in your home. And they said, I know, but I'm still in my room and it sucks. So it really is it's a very challenging situation, because you're seeing so many variable responses and so many challenging experiences. But I think overall, for a lot of older adults, they feel that they very much are in the line of fire right now. And I think a lot of them, they're looking for support, they're looking for guidance, and it's not a very pleasant experience to be going through overall.
But this is a generation, they've lived through a lot. A lot of them lived through the Great Depression, the war, the Holocaust. A lot have immigrated as refugees from Trump. There's a lot of trauma there. It's got to be difficult to another thing come around at the end of life like this for them.
Absolutely, and I think that's where it's reflected in a minority of my patients who certainly they have an incredible amount of resilience. And interestingly, when you look at the data on loneliness and social isolation, we find younger populations struggling with this a lot more than older people, which is actually quite surprising. But it's understandable. A lot of older people have been through a lot, and so they're ready to tackle issues. I think what's really been disappointing is for so many of them, they feel their rights and their opportunities to live with a high quality of life have been taken away from them. So the idea that I'm no longer able to spend the last few years looking forward to Christmas or Thanksgiving or Hanukkah, whatever the holidays might be, and folks who are saying, I don't mind taking a bit of a risk to visit other loved ones because I don't want to be isolated for another 8 months, and I'm just not really enjoying this. So it's interesting because there's a huge amount of resilience amongst our older population, but I think also a real challenge, kind of feeling that they're suffering in many other ways that were unexpected as well.
Now, Pat, you've been working in this field for a long time, writing about and researching elder care, long-term care in particular. what are your feelings now? Do you have a sense that, wow, finally I'm being listened to, or is it just a sense of frustration?
Well, I think we're in both very depressing times and very optimistic times, in the sense that I don't have to tell people here why it's depressing, but I think that we've focused attention to some extent on especially care and long-term care. But as I think we've already heard, we're not only talking about long-term care, we're talking about the entire range of care and the need to coordinate across all of those systems. I think one of the things we haven't talked about yet is the gender dimension in this. For the most part, when we're talking about long-term care, we're talking about care for women by women. And of course, care across the system is primarily by women. And we not only undervalue the care for the elderly, we also undervalue the work that is done by women, and especially the skilled nature of that work. And I'm very concerned when we talk about sending people without education and training into care for the elderly, whether that be at home or whether it be in long-term care, because this is very skilled work. And that's the piece that I'm less optimistic about being recognized. But I am optimistic that our attention is focused on this area very importantly, I think. I just hope we don't forget about it if things get a bit better.
And that you're right, that gendered aspect is forgotten, right? That it's care, people getting care, people delivering care, paid and unpaid. It's all dominated. It's 80–90% women. Yeah,
well, I started into this by looking at women's work. That was my master's thesis, ended up in a book called The Double Ghetto. And I moved from hospitals when our daughter broke her leg to realizing this was a classic area for women's work, into home care and then into long-term care. And it's the case across the board.
Right. Now I want to talk about a bit about this. We had the first wave, now we're getting a second wave. Maybe Samir, you can start us off. How maddening is it for you to see this almost Groundhog Day, seeing things happening all over again, that we seem to have learned nothing from the first wave to the second? Am I wrong that we've learned nothing?
Well, we've learned some things, right? And I think for everybody, let's, I think as Pat is saying, that there are things that we can look forward to, right? So, but being fair and honest in the assessment, I think it's quite distressing when we see hundreds of homes across the country yet again in outbreak, and we're seeing hundreds of people now who have died yet again in our second wave, almost exclusively in our long-term care homes. So what's the same, what's different? I think what's different is that in the first wave, we saw many homes that just were really not set up for success. They were already having significant staffing issues to begin with. Most homes were having trouble recruiting and retaining staff in the first place. So they were going in short-staffed. Number two, we didn't actually prioritize them for access to PPE when it was available. So homes that were not being allowed to be given supplies and permission, if you will, to use those supplies for fear that they would run out and be left in the cold. And then finally, COVID-19 was a tricky virus at the beginning. So we realized that unlike traditional things that we see in long-term care, such as influenza or that, with those viruses, when you get sick, it's pretty obvious who's sick and who's not. And we have some standardized treatments and protocols there. With COVID-19, there's so much asymptomatic or pre-symptomatic transmission. It's a sneaky virus. It can get in, it can sneak around. And that's why we've learned why we need to be much more aggressive around testing and isolation and tracing, especially in these settings. So we've come into the second wave knowing we now have a much better sense of how this virus behaves and what we can do to prevent it from spreading around or even getting in the first place. But and now homes have access to PPE, and I can say that's a good thing in Canada because we have a number of nursing homes in the United States that are still having problems getting even access to PPE testing and that. So those aren't so much the barriers. Now, the biggest challenges now going to our second wave are, number one, is we have unprecedented rates of community transmission. And the more COVID is in the community, the more it's out there circulating. And, and building on what Pat was saying about this ghettoization of work and these folks, we have to remember that these women, who are the majority of the workers in these settings, they tend to be more new Canadians. They tend to be more racialized. They tend not to be living in nice, big, leafy neighborhoods with big homes. Often we see patients who are coming in who are workers in long-term care, who were living 3 to a room, in a house in a poor part of town, in crowded accommodation, in a crowded neighborhood, where we're seeing positivity rates 14, 15%. So we have to realize that just by the very nature of how we've structured our long-term care system with very poorly paid workers, we're finding that they're also kind of getting re-victimized that way, and then inadvertently bringing it in. So what we need to do here is recognize the importance in the second wave of getting community transmission under control. And number two, making sure that we can fix the staffing issues. And provinces like Quebec and BC that have done a lot of good things in terms of trying to rebuild their staffing and stabilize their staffing situations are seeing better results overall now going into the second wave, despite the community transmission. Whereas in Ontario, where very little progress was made, we're seeing it have the highest number of homes in outbreak once again.
And Sharon, maybe you can build a bit on that. Staffing issues are a perpetual issue in healthcare. How are the frontline workers coping with this? Oh no, here we go again with the second wave.
Well, the second wave is way worse than the first one at this point, because during the first wave, we closed non-urgent services. So then a lot of patients who didn't have COVID were put on the backlog. And then also there was the fear aspect of people coming to the hospital. So back then we had less people coming to the hospital because they didn't want to get exposed. And now those people who stayed at home are now sicker than they were before. So we have more people that need hospital services, and we just don't have the resources.
And the staffing problems, do you talk about that among yourselves all the time, saying, boy, I wish we had more soldiers on the front line?
Yes. Staffing was never great, even before COVID. Now it's just a whole lot worse because everyone is just really sick and you're always on your feet. It's hard to take a break these days.
Well, hang in there. Now, Pat, on the more technical side, the staffing issue, can we do better in the second wave if we don't or haven't solved that fundamental problem of getting staff, adequate staff in homes?
I think the simple answer is no. That you go back to Romano, you go back to Hall, you look at those reports, and there's a call for a national labor force strategy in healthcare, and we simply haven't done anything about it. And I was prompted by the two we just heard from to think about what's a central mantra in the research we do, which is to say the conditions of work are the conditions of care. And the conditions, of course, staffing, the number of people who are there and the kinds of skills they have is absolutely critical. But there are a whole lot of other conditions, including the physical in the place, things like what happens to laundry, what happens to food. There are a whole lot of issues in long-term care that we should be thinking about in terms of a labor force strategy. And we haven't done anything about those parts. We contract out a lot of those services in ways that bring other people into the home. And the whole literature on the determinants of health should have taught us a long time ago that food and laundry are critical to health, for example, and so is cleaning. And if you look at the military reports, they make this very clear as well. And we haven't thought about those aspects in terms of our labor force strategy. The OECD and the World Health Organization and the International Labor Organization have been warning for years that we need a labor force strategy in terms of long-term care. And they mean by that home care as well as, and community services as well as what might be called nursing homes.
Now, I want you to expand a bit. You made a really important point that the better the work environment, the better the care, right? So we have to take care of the workers.
Exactly, and taking care of them in part means that there are full-time jobs available, that there's the possibility for some kind of autonomy, that there's the possibility for focusing on processes and not just tasks. It includes a wide range of aspects of the nature of the work, and job security, as well as pay and benefits and access to sick leave. And there are, in spite of the high unionized rate in this sector, there are still a lot of people who work without those protections, and there are still lower wages in long-term care and home care compared to hospital care, for example. We need some national and some province-wide strategies, and we have none. And to go back to what Samir said about BC, they did have some province-wide strategies that were very important, I think.
Yeah, such as making sure that workers didn't work in several homes, that they had full-time work, that decent pay. They did a lot to compare to, say, Ontario. And I just saw a little note go by on the chat. There are some younger people on our viewing today, so I want to just to expand. You mentioned the Hull report. That's something from a Royal Commission from 1964, which talked about some of these things at half a century ago. So I'd urge people to look back at that one of the most important reports ever. And of course, the Romano report in 2002, a very similar look at the healthcare system. And it also talked about home care, long-term care. So just to give some of that history for some of our younger viewers. So Samir, I'm wondering, we talk a lot about how we've failed our elders. Who's doing it right? Can we look around the world and say, this is what we should have been doing? And
yeah, I always hold Denmark up as my favorite kind of international example, and immediately people start saying, well, how can you compare Canada to Denmark? It's a small country. It's only about 5 or 6 million people. So of course they can do things, that we can't do. But I was so convinced and studying kind of what they'd done over the last 10 years that I actually took a bunch of deputy ministers and so the kind of the seconds in commands of our healthcare systems across Canada to Denmark 2 years ago, so that they could actually see firsthand, what they had done. And there were a few key principles, because Denmark, like Canada, say 20, 30 years ago, was facing a lot of the same issues. We chose, when we created Medicare back in 1966, I always joke that our original sin was that we only included in our universal healthcare system hospital care and physician services. So long-term care was excluded at that time, maybe because the average Canadian was 27 years of age at the time, and we didn't think we would actually need this care. And most of us didn't live beyond our 60s or 70s. So that was a pretty, I guess, a reasonable approach then. But the problem is we never adjusted our approach. And countries like Denmark and other Western European nations, they actually included things like pharmacare, which is still kind of an issue that we're considering, and long-term care is part of that. But then Denmark, like Canada, was spending a lot of money because they found hospitals were full of patients who couldn't go home. They didn't have enough institutional beds. And they asked, people in Denmark a simple question: where do you want to be? And people basically said, I want to stay in my home for as long as possible, something that 100% of Canadians in some recent polling, nearly 100% of people 65 plus said that's where they want to be as well. So we're very similar to Danes in that mindset, that we'd like to age in our homes as much as possible. Recently, we surveyed Ontarians, and we found 78% of Ontarians said they would rather receive care in their own homes than in a long-term care home. And that's basically what Denmark has done. They spend twice the amount that we do of their gross domestic product on spending on long-term care. Canada, by the way, spends about 30% less than the international average. So Denmark not only spends twice of what we do, but they spend higher than the OECD average. But they also make sure that 2/3 of their dollars that they spend are spent on providing home and community care, more intensive care than purely kind of nursing home level care. And they actually pay their workers a good wage. And so by doing all those sorts of things, they actually ended up closing thousands of hospital beds because they weren't filled with 15% of their patients like we are in Canada, waiting to go home or to a long-term care home. They're able to keep more people in their homes for much longer. And they were able to not build any new nursing home beds for a 20-year period. And so, it's a premise that we can actually accomplish in Canada, because right now 87% of our dollars in Canada are spent on institutionalizing people in care homes, which is a very expensive proposition overall. So the nice story is we actually have really good examples of other countries that I think have gotten it a lot better. I'm not going to say Denmark is perfect, but they're far further along than we are, and they're much in better state now because they started doing these things many years ago with a lot of foresight. But we can do these things, and there are even models from the US and other parts of the world that we could take to heart if we actually just reoriented. But I think back to what Pat was saying, we don't have a national strategy. And even though provinces and territories are thinking about this, and because they manage this at a local level, at a provincial territorial level, we don't have many provinces or territories that have done a huge heck of a lot to actually think about this overall paradigm as not just as a collective, what we call long-term care, including that whole continuum of care as well, and the workers who actually, are the backbone of that system as well.
Yeah, I think we hear a lot about Denmark, and they did a lot of things right. As you mentioned, foresight, listening to the people, what the people actually want, having deliberate policies, and putting the emphasis, I think, on quality of life rather than finding beds for people. So that's thanks for bringing that up. Now, Sharon, I wondered if you could talk a bit. The RNAO has been very outspoken during this crisis about the need for more care and better care, and calling for a care guarantee. Can you talk about that, about the need for guaranteeing an amount of hands-on care for patients in homes?
Yeah. So the RNAO has actually done a lot of research on long-term care over the last 20 years, tabling approximately 35 plus reports about funding and staffing models, which have been tabled to the government, and yet nothing has been done so far. The consistent demand has been an attention for an increase in the staff, changing the mix of staff, and with increasing funding support. There have been recommendations placed to the government last year in the long-term care homes public inquiry, which was led by the Honorable Justice Eileen Gillese in July 2019, and the advisory group from the Ontario government provided recommendations for 5 priority areas to increase the number of staff, change the culture of long-term care at both the systems and the individual level, improve workload and working conditions so that you can have staff retention, and then improve leadership and provide access to specialized expertise and to attract the right people for employment in long-term care. The RNAO has actually gone further to propose a nursing home basic care guarantee, which was submitted to the long-term care advisory group. So the basic care guarantee is a staffing formula that requires minimum staffing areas to make sure that there's an adequate knowledge range of people. So number one, the idea is to fund long-term care homes to provide a minimum of 4 hours of nursing and personal care to residents each day, having RNs provide 20% of the total care, RPNs at 25%, and personal support workers at 55%. So this 4-hour goal was something that the government did identify a few years ago as what they wanted to achieve earlier than this point, which hasn't been done yet. We would also like to have long-term care homes funded so that there can be 1 nurse practitioner for every 120 residents in the role of an attending NP or director of clinical care. We would also like to fund long-term care homes with 1 additional nursing full-time staff for infection control purposes so that there can be an improvement in training and education and orientation so that they can catch these slip-ups in infection control. And we would also like to fund long-term care to implement the following standards to disallow long-term care staff working in other long-term care homes, which means that there needs to be an increase in the amount of full-time positions, because right now most PSWs are part-time and have to work at other homes to make ends meet. We would like to ensure that nursing and personal care salaries are commiserated with those in other sectors, so have long-term care pay be comparable to hospitals. And we would also like to ensure that full-time employment includes benefits for staff so that we can have more staff retention. And then in addition, we would like more interprofessional staff in the long-term care homes, such as physiotherapy, rehabilitation therapy, speech therapy, social work, dietary, and dental care, etc., so that when these patients do get sicker, they don't have to go overwhelm the hospital systems. They can actually have the specialists come there to help them.
Yeah, so it comes back to our recurring theme that it's all about people, and we have to get the number of people in there to provide adequate care. And I should note the Ontario government has promised this 4 hours of hands-on care by 2025, but they've not budgeted any money for it. So we'll have to see if that's just a vague promise or if they'll follow through.
Well, the premier did come out on, they did that as a pre-budget announcement. This is kind of the game of politics, which just bothered me, because Monday, right before the budget, they came out and said, we will be the most innovative province. We will come out with 4 hours of care a day by 2024-25. So I'm sure Pat, myself, and Sharon, we're all going, yay, finally. And of course, then when the budget came out, as André was just saying, there was no money there. But the premier did respond when people like André and others asked the good questions, saying, "Where's the beef?" We were told that our commitment still stands, and don't worry, we'll get money when we need it. Well, I thought we said we were doing this. Anyways.
Yeah, the first time that they made that commitment was 2017, so they're just repeating what they said. So at this point, it is a waiting game.
Okay, well, we have some good skeptics on our panel. That's helpful. Now, Pat, I wanted to throw some of the questions that have been coming in to you. Some people are confused by the nomenclature about what's a nursing home, what's a long-term care home, what's a retirement home. How are they different? Can you help us sort that out a bit, Pat?
Well, it's perhaps easier to use nursing home than long-term care, because long-term care could cover the whole range of what goes on, although I know some people find that offensive terminology. But what we're really talking about is those places that provide 24-hour nursing care and receive a significant amount of public funding. Most of their money comes from the public. Those are the long-term care homes that are licensed and funded by the government for 24-hour care. Retirement homes are, for the most part, well, and I should say there are 3 forms of ownership there: for-profit, not-for-profit, and municipal. Municipal being legislated as required in towns of a certain size or cities of a certain size. Retirement homes have only recently actually become regulated. They aren't required in the sense of, they're limited regulations. You pay a lot of money to go to a retirement home. For the most part, they're private and they're private paid. In a nursing home, the fees are fixed. And if you can't afford those fees, which vary by the kind of room you have, if you can't afford those fees, then there is a subsidy available. So financial barriers should not prevent you from going into, for ease, let's call nursing homes. They can prevent you from going into a retirement home. We also have assisted living that is sort of partway in between those two. At least in this province, the nomenclature is different depending on which province, which jurisdiction you're in, province or territory. So that's the way it's organized in this province.
Great explanation. And I'll throw another easy question at you that's coming from our audience. They want to know, is there a best model of care? They've heard of things like butterfly care, Eden care, dementia villages. Is there one that's better than all of them?
I think the quick answer is no. We did a study for the City of Toronto on models of care, but in their homes, we've also been in 6 countries looking at homes in those countries, spending a week in them to see how well they do. And we've looked at virtually all of the major models in terms of long-term care. Just like we can learn from other countries, we can certainly learn from these models. And they have shared principles. The central one is more staff, more autonomy for the staff, more attention to the social and the emotional rather than focusing on tasks and the medical, more comfortable physical environments. Although I think it's interesting, they all say home-like, but our question was always, who's home? even within our group, we had very different ideas about what home should look like. So we have to raise some questions about that. So there are some very important principles shared by these models, but there is no magic solution. And there's no, I would say, in terms of Canada, the reason we need to talk about standards rather than standardization, there's a huge difference between being in downtown Toronto and being in Attawapiskat. And we can think about the same sorts of principles and standards applying, but we can't organize the care in exactly the same way in those places, just like we can't organize it exactly the same way as Norway, although I saw some lovely examples of good care in Norway.
Now, Samir, I see you nodding vigorously. Jump in there.
No, I agree. I always agree with everything that Pat says, and I think it's that idea that right now we've been hearing a lot about national long-term care standards, and certainly all the politicians I think across Canada have all done the requisite. My heart is broken. I feel bad for these families. We'll fix this forever. And I think one of our colleagues, I think Sharon mentioned earlier, that it was actually the previous government that announced the 4 hours of care in 2017, and then we have this new government. So it's kind of we repeat ourselves over and over, and we mentioned the Hall report and other reports that have kind of said the same things over and over. But I think it is that notion that when we start thinking about this question about national long-term care standards, I was having a conversation around this with our federal minister of health the other day, and and she was saying, like, money isn't our barrier actually as a federal government. We actually have a lot of it. It's the question is, how do you get all the provinces and territories that for the last 50 years have created all their different types of long-term care systems, because again, we left it up to them. And most provinces have created something recognizable as a home care system, as a nursing home system, as a retirement home system. Some are very blended, some are very separate, some are subsidized, some are completely publicly run. So it's all these various incarnations. But I think as Pat was saying, I think when we start thinking about national long-term care standards, I think this is where the issue becomes, how do we actually say, what is it that we aspire that every Canadian can expect when they're receiving long-term care? And that might even start from the back one step, saying, if people want to age in their homes, how do we make that possible? And sometimes that's not possible everywhere if you just don't have the staff or you don't have the resources in that. But then if you're starting to look at more of an institutional setting, what are those basic standards like? And there's some really good examples, especially during a pandemic. One model is called the greenhouse model. And it's like literally like you're actually living in a house where you actually just have, I don't want to always, use the term golden girls, if you will, but it's the idea that you have a shared house. It's purposely built where you actually have your own room, your own bathroom, for example, but you have a common area. And back to that idea about staff autonomy. You've got staff there who are like family members. They come every day. They help meet the needs of individuals. And they've actually shown, there was actually a recent study showing that in the US, where over 85,000 people or 100,000 people have died in nursing homes across the US right now alone. The greenhouse model, where there's a few hundred of these small house-like models, have done remarkably well because, again, you're actually having people in single-room accommodation. You don't have that foot traffic coming in and out for the laundry and everything else. A lot of it's just like people sheltering in their own homes, receiving that care, and often high quality care that can actually be done for, again, a reasonable cost. But it's about thinking outside the box and permitting those models to occur, and looking at how those models can actually work even better in rural and remote communities where it's hard to get, the economies of scale to make 120 bed a home actually work in that way. So I think, again, what's reassuring to me is we actually know what we need to do. It's more about the political will and the dollars to actually do it. And I'm hoping that at least maybe the benefit of the second wave was, if the first wave didn't, compel us enough to act with actual real conviction and action, maybe the second wave actually will.
So Samir just mentioned, we know what we need to do. We've probably known for a long time, but I'm interested from the panelists, where do we start? So Sharon, if you were the boss today, what would you do? What would be your first fix of the elder care system?
First fix would be hire more staff. when I did work in long-term care as a student in nursing school, I was a PSW, and it was me and one other PSW assigned to 32 patients. All of these patients, minus maybe 2, required total care, which means bathing, feeding, toileting, everything. So oftentimes you get behind because there's just so much to do and there's only 2 of you. These people also require assisted lifts, which means that 2 people have to attend to one of them at the same time, which also eats into this time. So in that report that the military posted about how people were in soiled diapers for a long time and it was inhumane, well, that's how it always is because there's only 2 of us and we just cannot do everything.
And you mentioned, you know, your route is kind of a very common one. You started as a PSW, became a nurse. Do we listen to those frontline workers who have so much experience like you? Are we paying enough attention to all the stuff they know? Why don't we listen to them more?
I don't know why nobody listens to us, but I feel like we've just been yelling into like a vacuum for the last 20 years, and people just nod and smile and move on to the next person.
But we're I think in this crisis, we're maybe appreciating a little bit more, especially the PSW side, maybe, if not listening, at least appreciating.
Yeah.
Okay.
I hope so.
It's a start. Now, Pat, where would you start? There's so much to do, it sounds like, from our discussion. Where would you start?
Well, I think we need to dare to dream and think about how we can make long-term residential care a positive option, as well as home care a positive option. I think in terms of home care, we have to remember lots of people don't have a home, and for lots of people, their home is not safe, and safe in all kinds of ways, as we've been seeing in this pandemic. And it can be lonely, and it's often primarily dependent on the unpaid work of women to provide the care. So while I certainly want to support home care, I want to make it better. I think we need to, in terms of home care, also think bigger, like the 15-minute city with sidewalks that are cleaned and shops you can walk to and get access to, and going beyond the absolutely critical staffing level, which is of course, the bottom line. I also think that we have to establish national standards. We have to say to the jurisdictions, as we did with the Canada Health Act, if you want the money, you have to meet these standards, and you have to show us you meet these standards. We have to have verified data in terms of meeting those standards. And the last thing I would say in relation to that, in my Dare to Dream, I think you've heard me say this before, André, that we were in a place in Norway where the long-term care home was physically built into a structure that included the town cinema, the town swimming pool, a spa, a climbing wall, a daycare center. It was all physically integrated in the same place. And it brought generations together as well. So, you know, we have to think bigger.
Yeah, bigger and smarter. You make a really important point that most of our elders actually live in the community, right? So we have to make the communities more friendly so that institutionalization doesn't become the default.
Right.
Okay. Now, Samir, where do you want to start? Maybe you can talk to us about, you just posted the virtual long-term care. Maybe that's a way of the future. Where would you start with fixing things?
I think again, I think goes back to, you know, what Pat and Sharon were saying, was that fundamentally we have to realize that we just grossly underinvested in our system by 30%. So if we just want to, you know, forget being below average, like if Canadians just want to aim to be average, right, where there's an average provider of long-term care, I mean, that would boost our current $22 billion of spending to around 30 billion, right? Sounds like a lot of money, but, you know, again, the key is that we're all going to be aging. We're all going to need some form of long-term care, you know, as we age. So we need to think about how we actually invest in this. So first of all, it would but what would you do with that money? And I think what Pat was saying very clearly is, sure, we could give you more money, and we've been putting more money into the system, but what are the results that we're getting? How do we know that we're actually achieving good quality standards? And so with some of the mechanisms we currently have, we can actually see what are rates of antipsychotic utilization, restraint use, and as markers of quality in care homes to actually see, are we doing that? And often, back to this root of staffing, we often see some small homes in isolated communities that have super big staffing issues, where you see some of these quality issues really at play. So we shouldn't be working in a system that penalizes homes, but really supports homes by making sure that they do have the staffing. We do have ways of bringing people into the system and supporting them, because I think, Pat said beautifully before, the conditions of work, really reflect the conditions of care. If we can make this a place where people want to work, where people who need to live in a nursing home, for example, can live well, but also people who want to stay in their communities can live well, that's where we can. But I think it comes to the investment that really reflects staffing, good, appropriate staffing, and that we actually see that we are meeting quality standards in a way that are helping people to stay at home. And, as Pat was noting, that 75% of the home care hours that people receive are from unpaid family caregivers. So how are we doing this so that we're not burning them out, but we actually make sure that they're feeling engaged and supported? And how do we make sure that the staff who are working in long-term care settings don't want to leave after 18 months, which is the average lifespan of a staff in a long-term care home? So it's actually looking at those things that know that those investments are actually achieving the quality that we want. And then frankly, a lot of people think, well, $7 billion, where are you going to get that? Well, we waste so much money right now funding very expensive hospital bed days. Right now, it's $730 a day in Ontario to have someone living in a hospital, an acute care hospital, while they're waiting to go to their own home for home care that's not available right now, which is only $103 a day for a very high needs individual. So we actually are spending a lot of money, but really in poor ways. And I think actually, again, when you make the right investments in the right place, when you actually hold that accountability, that's actually how you start seeing us become more average. And frankly, if at this point we can aim for average, I'd be happy, because aiming for below average is not getting us the international news that we want.
I think we could talk about.
Yes, sir. Go ahead, Pat.
A short thing. I think we should talk about it as an investment in the care economy.
Yeah, so I think you all had the same theme, like get the right care at the right place at the right time, invest a little smarter rather than wasting. So all good things, a very provocative discussion to give us a lot to talk about in the breakout rooms. So I think we're going to go magically virtually into these breakout rooms, and we'll chat for a bit. You have a chance to ask our panelists more questions directly, and then we'll come back for a wrap up in a few minutes. So I'm going to sit back and see how magically I get sent somewhere.
Welcome back, everybody. Thank you so much for your engagement in the breakout rooms. We had a very rich discussion in our room that had a number of people wanting to be spurred to action items, and we will do a follow-up with some resources around action items and advocacy efforts, including through potentially through your own efforts. So please drop those into the chat if you like, and we can aggregate them. Also, if you're looking for advocacy places to point to, we can support that through, again, the collection of items. We can't connect you all by email to go off and march on Ottawa or in Queen's Park or on the Capitol buildings of provincial legislatures just yet. But our platform is evolving, so stay tuned for a future first policy response opportunity potentially to do that. So we're just going to do very quick roundups in our breakout rooms. I'll start with our breakout room with André Picard. Lots of discussion around the importance of supporting caregivers, family caregivers in particular, and having a quality of life that should be the same regardless of the setting. And André noting that came from deliberate policy choices that we have to make. We also had a bit of a discussion on the public-private distinction in the delivery of long-term care. It's a really rich area of discussion, not something we got into in the plenary. So we learned a bit about the different modalities of how private and public works and the debate around that. And we also had a discussion around and heard on the front lines from One Healthcare workers who noted that there were no adjustment to plans that were made in their particular care setting due to COVID-19 and how impactful that was. and how COVID-19 didn't affect just patients directly, but indirectly seemed to really precipitate the decline of a number of patients in long-term care facilities, especially those with dementia. Those were the takeaways from our room, but ended on hopefully a fundamentally hopeful note. Matthew, do you want to go next?
Yeah, sure. So we had a fascinating conversation. I learned a lot. I've been learning a lot throughout this conversation. We were with Samir, and ran out of time, and lots of people had questions that couldn't get answered or addressed, or wanted to make comments and offer their own insights. So again, I'd encourage people to drop ideas into the chat, and we can do some follow-up. I won't try and summarize all of the conversation, but I'll make, I think, just one overarching observation, which I think summarizes a lot of our discussion. And that was a lot of people were talking about creative options, bringing in additional partners, how community members who don't normally participate in the long-term care system can get engaged, how we have to think about this through a systems lens, and all of the various partners and stakeholders that do not get as fully mobilized or don't have clear pathways to help and support. And at the same time, the doctor was talking about how, and others were as well, people are getting sick, people who are providing care are getting sick, they are traumatized, they are stressed, they aren't well paid, and sometimes not well respected. And so that tension with people wanting to find creative ways of bringing public servants in or community organizations in to help, but the challenge that you face on the front lines. So a lot of talk about how to think about this through a systems lens and a community lens, and I thought they were really cool ideas.
Thanks, Matthew. Next, Stephanie, and you were in the room with Sharon. Oh, and we need to unmute.
It has to happen at least once during a Zoom call. It's mandatory. Thanks very much. We had a great conversation as well. We had, some of the same themes that you've mentioned came up. We spoke a lot about recruiting, and one thing that Sharon said that really stood out to me is that even in emergency rooms right now, they're having a hard time getting enough RNs because people are so afraid of the virus and about not having enough PPE and the risks that are happening. So even people who are trained RNs are opting out right now. So just as that's a problem in emergency rooms, that's also a problem in long-term care settings as well. So recruitment remains an issue because, as Pat mentioned earlier, a lot of the people who are going into this field are low-income women, a lot of immigrant women who need to have that motivation that if they spend the money for their training and to get their certifications, that they're going to be able to recoup it through the field, which right now there's not a lot of guarantee of, and at least not without working in multiple homes and then risking spreading the virus further. And the another thing that was really interesting is we actually had 2 interior designers in our group who both had experience working with hospitals before. And there's a question about the fact that hospitals get a lot more, got to get a lot more funding essentially for building and renovating and making sure that they've got top of the line facilities, whereas nursing homes do not. So there's the question of funding for actually building and maintaining the facilities, and also the fact that the frontline workers aren't heard from when it comes to making these decisions about how do you build, how do you build and design a healthcare space in a way that supports the patients and the residents, as well as the frontline workers. So that could be perhaps another opportunity for making sure that there's that those people are heard from. And the only other thing I would add is there was some discussion about training as well, and about how it's not always consistent and not always
you might receive, skills training such as, de-escalation, dealing with patients with dementia in a nursing setting in a hospital, but not necessarily in a long-term care home. So that's something else that could be fairly easy to standardize or implement.
Thank you, Stephanie. And finally, Famida, and you're in the room with Pat Armstrong.
Yeah, thanks, Karim. We had some really good discussion. We started off by talking about, in terms of policy change, having a minimum standard for education or trying to shoot for that gold standard when it comes to taking care of individuals in long-term care centers. There's this misconception that this work is easy, and it's not easy. Having that standard of education, Pat gave an example of one worker who recalled when they started working with elderly patients, instead of being taught how to feed the patient, they were shown a video, and that actually scared them even more. And if there is a shortage of PSW workers, pay more money to get people who will work in those positions instead of finding people who will work for that low salary. And if we don't have that money, going and looking for registered nurses or others who will work in those facilities. We talked a little bit about the social contract as a nation, how we need to reconceptualize this concept of work and get into more of a caring economy. Someone else mentioned that we need to reinstate community and family engagement with elder care, creating an environment where families and the community members are able to participate in that care. We had someone who is an occupational therapist. They talked a little bit about this idea of embracing a little bit more risk in the sense of encouraging patients to do things, or I shouldn't use the word patient, my apologies, elderly individuals, encouraging them to do activities that we normally see them as too frail to do. So one example, a lot of times when elderly individuals come into a home, even if they know how to walk, they're put into a wheelchair. And a lot of families will recount that, their family members went into the facility and they knew how to walk. But because we have this idea that, if you're elderly, you're frail, you need to be taken care of carefully, they get put into wheelchairs, which limits their mobilities. So that I thought was interesting. So it was a lot of really good discussion.
Thank you, Famida, and thanks to all of you for participating in this event. Again, First Policy Response is an initiative of the Brookfield Institute for Innovation and Entrepreneurship, the Ryerson Leadership Lab, and Matthew Mendelsohn. We're so pleased to be able to put on this event with the National Institute on Aging. Samir or Michael Nissen, Executive Director, don't know if you want to say a final word or two on behalf of the National Institute before we close.
I'm happy to lead off and just say again, thank you very much for so many people being engaged in the conversation today. This is our goal, is just to make sure that all of us can be part of the conversation and really, figuring out how we can actually move the policy conversation forward in a positive way. And so I think we shared some great ideas. If you're interested in learning more about these extensive issues, certainly I'll put out the link to our reports that we're writing extensively around long-term care, because at least it allows us to have a conversation about how we can move forward and make sure it's evidence informed. So thank you. And a little plug, we just released our COVID visit risk tool today. So I'll put it out in the chat box right now. Another way that you can use evidence information to decide how to visit safely with others.
Thank you so much, Samir. Thank you to André Picard, to Sharon Nwamadi, to Pat Armstrong, to Dr. Sinha, and to all of you for participating in this event. This was not the last piece of this. I know a lot of people are already engaged in this issue. We hope this has deepened your knowledge, created some connectivity to each other, connectivity to our project, which we hope can aggregate, again, people who would not necessarily be in the same room as each other, the academics, the frontline workers, the caregivers, the policymakers, and others. Thank you so much for joining us today, and we wish you a good week.